One of the most important things in giving patients lenvatinib or any of the agents for systemic therapy of differentiated thyroid cancer is being able to define the population that would most benefit. These agents are approved only for radioactive iodine refractory patients. That means that iodine has been used in the past and either was not absorbed by the cancer, so they're iodine non-avid, or it was taken up by the cancer, but they proceeded to progress anyway, in which case we would deem that patient to be radioactive iodine refractory. In the actual trial, there was another criteria that if patients had exceeded 600 millicuries, they're also basically considered radioactive iodine refractory. That tends to be a little bit more of a controversial criteria, but certainly was one that was important in the study. Most patients, the basis for that is that most patients, if they're going to get a benefit and be cured by radioactive iodine, are usually cured by the time they've had 400 millicuries and certainly by 600 millicuries. So that's the justification for that, although it was rarely used in the study. The patients who are now being treated occasionally with lenvatinib, some of them are not actually even eligible for radioactive iodine. And this includes patients who have large masses in the neck that are not amenable to surgery. When the patients have a full intact thyroid gland, radioactive iodine is not indicated. Now, there are some approaches to make them radioactive iodine amenable by trying to ablate the thyroid using radioactive iodine first and then do a treatment dose. However, in our experience, if you do that, we still end up with a tumor that obviously was more aggressive, possibly more poorly differentiated. And in most cases, those patients won't take up iodine anyway. So in general, we tend to say that patients who still have an intact thyroid due to the fact that they have invasive cancer are in general a patient profile that I would not find amenable to radioactive iodine therapy. And for patients who do have radioactive iodine refractory differentiated thyroid cancer, as I mentioned in another instance, sorafenib and lenvatinib are now approved by the FDA, the EU, and many countries globally for the treatment of this cancer. Sorafenib was approved initially, and then lenvatinib was approved 2 years later. How I decide on which one to use is an interesting question because there can be some times when I'll prefer one over the other. In most cases, I tend to pick lenvatinib first. And the answer to why that is that we already know we have good data that shows from the Journal of Clinical Oncology paper that patients who are over 65, if they get lenvatinib, are more likely to have an increase in their overall survival. That has not been shown for sorafenib. And for that reason, for patients over 65, as a general rule, I will choose lenvatinib first. A reason not to take lenvatinib goes back to the AE profile. So a patient who has a lot of trouble controlling their blood pressure, and I did have one of these, patient who's already on 3 blood pressure medicines without being on lenvatinib is going to be very difficult to control if they're started on lenvatinib, and those are the patients that I might start first on sorafenib. So I have to pick and choose a little bit which patients I use, but in most cases, lenvatinib, given its really good response rate of 63%, and it's or over 60%, and its fairly well-tolerated profile, side effect profile, in general makes it my first choice of treatment. There are some patients as well who might have more indolent disease, and I know in some countries, basically due to approvals, sometimes lenvatinib is not available, in which case obviously sorafenib would be used first. But in cases where both are available, it is important to know that if you did have to choose sorafenib first, or if the patients have been on sorafenib for a while, maybe before lenvatinib was approved in your country, there was interesting data from the SELECT trial that said that if they received lenvatinib in the first line, they got 18 months progression-free survival. But if they received it in the second line, and in most cases it was second line to sorafenib, the progression-free survival was 15 months, which is still rather good. So virtually all of my patients will be exposed to lenvatinib unless there's a very, very strong counterindication. And I find that for the most part, this helps most of my patients have a very good progression-free survival. The one caveat I'll say to that is that because of these toxicity profiles, they're not insignificant. They can be dangerous. It's important that the person, not the investigator, but the practitioner who's prescribing it, have a close relationship with the patient. And because of the blood pressure issues, we recommend patients coming in every 2 weeks for the first 2 cycles to make sure that their blood pressure is well controlled. And also sometimes what we'll do is we'll actually give them the prescription for an antihypertensive so that if it starts to go up while they're at home in between visits, they're able to go to a pharmacy and actually get a prescription filled in time to be able to bring that blood pressure back down. So managing side effects is not trivial with lenvatinib or sorafenib, and it's very important to have a close relationship with the patient, and especially good communication during those first 2 to 6 months to manage any side effects that might be coming up.